I've been asked to come and speak a little bit about chaplaincy with you. Um, when I was just saying that originally it wasn't going to be me. I wasn't meant to be here. I was meant to be out on the wards. However, the persons who were supposed to be doing this presentation are not here. So apologies for any disappointments there. And welcome. I'd like to say thank you for asking us to speak about chaplaincy, because I think it's a wonderful thing. We chose this particular slide to begin with at the beginning because often, when people think about chaplaincy, one of the things that we were told is, do you all sit around on clouds? Well, no, we don't. Let me introduce our team first of all. The chaplaincy team, it's made up of men and women of different faiths and beliefs. We're all fully trained professionals. And as a team, we seek to be person-centered. It means we're led by you. The joy is, I often say to people when I go and visit, I've not come with any tablets, I've not come with any pills, I've not come with any injections. I've come to say hello. I'm not stealing souls. I've no agenda, no judgments, and we're totally confidential. If you look, you can see that we're made. The team's actually made up. The Anglican Free Church chaplains. There's myself. There's my colleague Sonia, Ben, who's our head of chaplaincy, Joe, who's our deputy head of chaplaincy, and is you may have encountered Joe. She used to be one of the matrons in the hospital, but found that she felt she had a calling, and she's actually going to be ordained this summer, I think. Anthony, who's our Pentecostal chaplain. Then we have some other. We have Jack and Denise and Helen. Then, in terms of our Roman Catholic colleagues, we have Father Ben Griffiths and Father Dwayne Riley. For our Jewish patients, there's the Rabbi Al Bishet and Rabbi Jason Kleiman. For our Hindu people, it's Haridas Shukla and Amrish Pandli. For our Muslim patients, we have Mufti Zubair Butt, and I should explain, Mufti is a term given within the Islamic community. Zubair is incredibly learned and has studied extensively, so that this Mufti is a title of honour as well. It means he can interpret the various Islamic laws, and his interpretations and knowledge are often sought out. And then we have Fazila, who's with us, and Dr. Sarah, you may have come across. I'm sorry we've missed her off. But then we also have our non-religious pastoral care supporter, Paula, who joined us probably about 9 months back. And some people say, well, why does a chaplaincy need a non-religious member of the team? Surely all chaplains are religious. Well, that's what we're trying to help people to understand. Many people associate the word chaplain with religion, and that's why our non-religious, our pastoral member of the team is called a pastoral carer, because about 50% of the population at the moment identify as being non-religious, and we felt it was appropriate for the team, seeing as we represent the major beliefs within the area and the hospital, to sort of acknowledge the fact that many people have strong beliefs and moral values that don't necessarily relate to a religion. Spirituality is what gives shape and meaning to life. It's about being in tune with yourself, knowing what sustains you. Now, for some people that's religion, and for others it might be the arts, nature, family, your pets. She does much the same as the other chaplains do, just without religion, or as she says, or a dog collar. We're all here to walk alongside someone for as long as they need us. But you could say that we're the stranger at the bus stop who can listen to you and support you until you feel ready to get off at the next stop. So that's the team. I suppose my first question to yourselves might be, what do you think the chaplaincy team does? We're a small team, but what do you think? What do you think we do? And there was silence again. friend of mine used to say that misery in a presentation is offer comfort, says Joanne. Yes, we do. That's a major part of it, being alongside people at a vulnerable time. And that's why chaplaincy doesn't have an agenda. It doesn't, I think one of the difficulties is that people think, because they've got a dog collar on, that somehow when the chaplains come, they're either a step away from the Grim Reaper, or they've come to steal a person's soul. I actually met a member of staff who'd worked for the trust yesterday. She'd worked for the trust, she was telling me, 2 years, and she didn't know that there was a chaplaincy team available in the hospital. She said, I thought that if any patient needed some guidance, that we had to ring outside. I said, no, there's a team available. So yeah, that's one of the things. It's one of the major aspects we do is to walk alongside a person. And being person-centered, as you all know, is incredibly difficult because it requires, you really do put the person at the center. But it's a major part of what we're committed to as chaplains. Anything else? Okay. Well, let me show you a slide that was created, and it's full of stereotypes that people think of when we say chaplaincy, because a lot of people consider that chaplaincy is just there for funerals at the end of life, weddings, christenings, preach, pray, and we do all of those, but we also do other things as well. When people are asked about chaplaincy, obviously they said they thought it might be multicultural, multi-religious. You can see the Grim Reaper in the top left-hand corner. That's a common perception, that somehow you'll only get a chaplain visiting you if you're dying. It's amazing how many people have been frightened by a chaplain appearing. Obviously, yes, there's prayer. I like the top left-hand corner with the sort of the heart in the clouds, because I think that represents what chaplaincy is very much about. Take, sort of that kind of compassion and that love to people. Matters of faith, matters of spirituality. I suppose that's one of the questions that we do always consider with staff a lot. It's the difference between sort of faith, religion, spirituality, because people tend to only think of chaplains as dealing with faith matters, but we're also there for pastoral and spiritual matters, and I'll talk a bit more about that shortly. Any of those pictures strike you? You're all being very good, thank you. Obviously, another aspect of chaplaincy is the provision of, as you can see here, there's a Torah scroll. We do have a number of religious texts available for people. Many of them are available, obviously, in the hospital. When we give them, they're theirs to keep. We don't want them back because, obviously, with infection control. But reading can be incredibly important to a lot of patients. And it's one of those things, I think we sometimes are so busy that we forget. Well, the answer says faith, yes. It's an area that we do look at with people. We're there to support you in your faith. We're not going to come along in chaplaincy. When we say we'll come alongside you, that's exactly what we'll do. I'm not there, and none of my colleagues are there to convert anybody. And this is a really big thing for us, sort of within the National Health Service policies and guidelines, but also within our own makeup. We're there to be alongside people, not to convert, and or change anybody's religion from or faith or belief from what it is. I mean, my friends often laugh when I tell them that when I was over at Salford, I got a phone call from a member of staff who said, "I'd like you to come and see a patient of mine, but I must tell you, they're a pagan. Will you still come?" And I said, "Yeah, of course I'll come. It's what we do." And I came to see this particular lady, and her first comment to me was, "I'm a witch. Will you see me?" And I said, "Well, I'm here. How can we support you?" And some people, when this was mentioned afterwards, were a bit surprised. You're a chaplain. What are you doing going to see a witch? My argument was, here was a person in need. If you say you're person-centered, then you put that person first. Well, her beliefs and my beliefs might be totally very, different, but our concern in the hospital is, what's that patient going through? Because to be a patient, your world shrinks to the size of your bed. And it's a very lonely experience in many ways. To have someone come alongside you can be a great strength. And therefore, it's really important to us that that strength be given, that support be given in the way that's appropriate for the patient. So, as I say, we do a lot of things. So here's a few of the things that we do. The first one you'll notice right at the top is staff support. And this is a really interesting one for us in chaplaincy, because the number of times we'll go, staff will call us, somebody's end of life, somebody's in distress, and we go and we'll see the patient. But when we encounter people in distress, as we do throughout their life in the hospital, it has an impact on ourselves. And I think staff are really good at denying this. You say to a member of staff, you're dealing with this person, are you okay? And they'll be, "Oh, yeah, I'm fine. And sometimes you can see that actually they're not fine, but they're carrying on. So one of our big messages in chaplaincy to staff is that we're there for anybody who comes in contact with the hospital. So that's patient, family, friend, anybody. But in particular for the staff, we're there as a resource. We're there as a support for them as well. And like I mentioned, we're completely confidential. So, if you're struggling, we're there. Obviously, we've talked about prayer. We will go and pray with people if they ask for it. So pastoral care, support at the end of life, baptism, bedside weddings. That's one of those interesting aspects that happens in hospital. If a patient is in a situation where the doctors say that they're reaching the end of life, they're not going to be leaving hospital, and they'd like to get married, and they're willing to do it via under the auspices of the Church of England, we can arrange to get an archbishop's license for them. Usually take, within the day. It has been known for us to start this process first thing in the morning, and by tea time be able to conduct a wedding service for a couple. Equally, if somebody wants a non-religious wedding, a civil wedding, we've had contacts with the registrar's office, and we've had them come in and do the wedding. Equally, some people wanted blessings after they've had a civil wedding. So that's one of the things we can do. Non-judgmental. As I say, I can't emphasize enough. That's our big thing. I'm not there. None of us are there to take your souls. Funerals, we do them. Time. That's probably one of our greatest gifts. If you're dealing with somebody and they need time, we can give it. Baby naming. That's very popular, particularly on the baby units. Holy Communion. Yes, Joanne, guidance and reassurance in times of worry. We'll do. Remembrance services. We do one every sort of November, December time. That's we called it a time to remember, and it's for anybody who's lost a little one or a child, because we all need to remember at times, and it can be a great comfort and strength if you can come together. But it's also about being able to tell your story, sometimes with people that you don't need to justify yourself with. You can just tell them because you know that they understand. We are looking at the possibility of an adult version of that, because again, a lot of people lose adults in the hospital, and they equally need the opportunity to remember. Carol concerts. We've not been able to do as many of them in recent years. We've been online, but obviously we're hoping we're going to be able to go back to doing those in person again. Spiritual guidance, patient support, bereavement support, a listening ear, confidential, as I say, the only time. So I think this is one of the things that we often have to remind people as well when we go on the wards, that the chaplaincy team is part of the hospital staff team and therefore is bound by exactly the same rules and regulations as every other member of staff. Which, you know, we've had cases where staff have sort of said, "Oh, are you allowed on the ward?" And we've actually had to say to them, "Yes, we are." We've actually had the director of nursing having to tell certain teams that we are part of the hospital team and therefore, yes, we are allowed on the wards. Support with faith and belief, non-religious support, and obviously well-being support. So I hope you can see that it's a variety, you know, that we offer. So multi-denominational, looking at the issues of pastoral, spiritual, and religious care, things that give you shape and meaning. You know, we're trained, we're experienced, and our aim is to provide individualised care, just as it is for everybody else. We're here for patients, parents, families, and for you as well as the wellbeing champions, because it may well be that you're sometimes we're caring that much for the well-being of others. It's so easy to neglect ourselves, isn't it? If you need to talk, or more importantly, if you need someone to listen, chaplaincy can support you. You can come and arrange a meeting, you can come on a one-to-one basis or a team basis. If you need to refer a patient to a carer, or you need to talk to someone yourself, you can email us or you can call us, and contact details are available. And as I say, Paula, our non-religious pastoral carer, is there for a dedicated and responsive service for staff. And it ensures that the voices of non-religious people are heard in the design and delivery of our service. You know, it's something that's becoming increasingly important to us, that we're able to offer that, to care for all beliefs, all faiths, all belief systems as far as possible, and to walk alongside you. And obviously we operate a 24/7 service, which is very interesting for us. I thought what I'd do, I'd give you an idea of what a day in my life, the life of a hospital chaplain, pastoral carer looks like. So, for example, for me, the other day, the alarm went off at 5 a.m. and I do much the same as you all do. Think about turning it off and turning over. But I drag myself out of bed, shower, grab a drink, piece of toast, check my bag to see if I've got the equipment I need for the day, my headphones, my scrubs, the Bible, the pastoral prayers, and lunch. I say lunch, that's if I've been organised, it's ready for me to grab and pop in the bag. If not, like yesterday, it was like a momentary panic. See what's in, have a quick look and see what's in the fridge, throw together a cheese sandwich, and hope to hit the road by usually about 20 to 6. In the morning, depending on the weather and the traffic, my journey will take me about 45 to 50 minutes. And I like listening to the radio. I don't know if you're particularly radio too, especially at about 5:47. There's a pause for thought each day. Sometimes I find the thought provoking. Other times I find it very preachy. But I use that time to mentally plan for the day ahead. I make a plan. Though often this is like plan A, because in reality, it's usually plan F or G that I get to. So I get to the car park about 6:30, deal with the barrier, and sometimes it won't let me in, despite the fact it recognises my number and the challenges of parking. and head to the office in Trust Headquarters. I'm often the first, if not one of the first, to arrive. Switch on the computer and hope that it's going to be nice to me. Wipe all the desk and all the touch points down while waiting for the computer to decide what it wants to do and go and make a brew. Get logged on, check the chaplaincy database. Basically, that will tell us which patients are still in, who's gone out or gone home or elsewhere, and then I can catch up on emails, reading articles and research up until the morning huddle at about 9:15 when the team come together virtually. It's my turn for reflection. And I read them a Pam Ayres poem yesterday about a hedgehog being squashed because on my way into work, a pigeon bounced off my windscreen, and it made me think about how many people bounce off our emotional windscreens and how occasionally some will crack it and how we deal with that. We then discuss what's going in and on around the hospital, if anyone has any meetings, sort of where people are, so that we've got a rough idea. And that when that's finished, I can start my day, catch up with colleagues, discuss the patients that need to visit and allocate accordingly. I've got 9 to see. 2 of them are alphas, which means we see these patients daily because they're special needs, special struggling. So plan A is to spend the morning on my visits. I went off and saw 2 alphas and another patient, and then my pager went off, had to find a phone. When you're on a corridor, that can be difficult. Patient is nearing end of life and family would like prayers at the bedside. So I rushed back to the office, collect the anointing oils in a prayer book, arrive on the ward. Now, on a good day, I'd be ushered into a side room. But that wasn't one of those days. I was shown into a 4-bed bay and went behind the magic curtains. You know the magic curtains? We pull them around the patient and everything that's said inside suddenly becomes silent and confidential and private, and none of the other patients can hear. Well, the family were very distressed and told me they were religious. They weren't religious, but the patient was. We often get that. And they felt that the patient would like prayers. And it's one of those interesting ones because if the patient's still aware, I have one set of prayers I can use. If they're unconscious, I have another set of prayers I can use. And if sadly they've died, well, then I have another set. And that's why I needed to collect my prayer book. But then before I checked to see whether the staff are okay when I'm leaving and offer support. Interestingly enough, staff are really good at declining it. But every now and then you do know that it needs to, they need it. I wonder if they feel that this is their job, so they don't need support. Anyway, this took about an hour, so I'm up to plan C. I try to catch a few patients before they have their lunch, but the pager goes off again. Again, it's go and find a phone. And this time I'm off to neonatal for an emergency baptism. I run back to the office, collect the baptism card, and then onto the ward. Again, if the family needs me support, I stay a while to support them. And that means it's too late to visit any other patients as they'll be having their lunch. I'll see if they can do a little bit of visiting later. Heading back to the office, a member of staff stops me and they're struggling. So I stop to chat and eventually arrive back at the office around 1:30. I need to type up my visits at this point and the calls. So I do this while eating my thrown together sandwich and realise I'm not going to get to do any further visits today as I have a family meeting. I need to ring and talk to the family of a friend about their loved one for an upcoming funeral that I'll be doing next week. I think this is moving on to plan F now. Speak to my colleagues and tell them about the patients that I didn't get to see, and they'll try to see them later on or tomorrow. Have about half an hour to do a family meeting before I need to take another funeral at 3 o'clock and time to get there. The family meeting took about 20 minutes and I've taken the notes. They've asked me to ring other members of the family, so I'll have to do that tomorrow, and then I'll have to script that funeral and I'll have to try and plan time to do that. I don't want to leave it too long between talking to the family and actually getting the thoughts down on paper. Head to the car to drive to the crematorium. I've only given myself 30 minutes. Usually I try to give myself 40 to get there. I hope the traffic's okay, but call the office and tell them I've arrived at the crematorium in keeping with the lone worker policy. Pop my head in the door with the crematorium attendants to let them know I've arrived and check that the music's all sorted. All okay. Go outside to wait for the hearse and the elderly lady walks over to me and introduces herself to me. She's the lady I've spoken to on the phone about a week ago. And she tells me that there's only going to be her and another neighbour who will come. So that's it. I go into the crematorium. The service takes about 20 minutes. I waited outside afterwards as the two mourners who came thanked me for the service and said they were sorry that more people hadn't attended. Interesting. I reflect on the fact the last service I did, there was only me and the funeral director. I believe so strongly that every life, every death, every person deserves acknowledgement and dignity. Plan F was to head to LGI after the funeral because I'm closer to there, but I'm on call and I'd informed colleagues and switchboard that I'd be turning off for 30 minutes. Turn the pager back on as I walk into the car and it rings out immediately like it's been waiting. Get in the car and phone on my mobile. I've got to go back to Jimmy's to see an elderly patient who's distressed and need to talk. Tell them I'm on my way and head off. It's 20 to 4 now and I think we're on to plan G. Went to see the patient and was actually with her for over an hour. Went back to the office and recorded the visit. I come off call at 4:30 and was due to finish then. I wipe the desk and touch points and head out to the car. But now it's 5:45, it's time to head home. I use the journey home to reflect on how my day has gone and think about how it went and bookmark things in for tomorrow. So it's gone 7 by the time that I reach home. I'm knackered. It's too tired to cook. So I make a sandwich and put some chewing gum TV on just to unwind before bed. I hope that if you've listened, you've recognised, oh yeah, points in that. What I'm trying to show is that no, like every other member of staff for chaplaincy, no 2 days are ever the same. And we never know when we start off where we're going to end up. I think it's very much the same as other staff as well. If I can emphasise anything, it's the fact that chaplains are part of the hospital team. We all have the same worries as well. So I want to move on, and what I thought I'd do now is actually look a bit at this idea of spiritual care. Let me see. So something slightly different. As you look at the screen, what do you see? What do you see in the left-hand picture? Somebody said this. Some have seen the seal. That's good. And somebody's just said they've seen the polar bear. So Claire says she sees both. Someone says it. Yep, polar bear or a seal. Brilliant. If you see the black shape first, you'll see the seal. If you see the white head at the bottom, you'll see the polar bear. And it's one of my favourites, as is the one on the right. What do you see when you look at the picture on the right? A woman, a lady, an old lady, a woman, a young lady. Ah, now you see this is one of my favourites, because depending on how you look at this, you might see a young lady looking away from you or an old lady looking towards you. And I always like to say, you know, optical illusions are around all the time. I don't know, there's been a series recently on social media saying apparently that if you can be analysed by the way you interpret an optical illusion. I don't know if I totally agree with it, but some of the things they say can be very interesting. Let me move on. What do you see, and what do you see here? Two people, one with a guitar, an old couple and a vase, male and female face with images of yep, first two old faces and then people sat. It's really, again, this is another one I like, because some people see a golden vase in the middle. Some people see, someone said, two people sat. one with a guitar, one who looks like they're carrying various plates on their head. I once had somebody say that if you look next to that, you see a bottle, and someone said, "I think this is a party," and I thought it was really interesting, because this is the important thing I think with spiritual care. We often see what we expect to see. Immanuel Kant said, "We see things as we are, not necessarily as they are, but we see what we expect to see and according to our own viewpoint." And this is why I think spiritual care can be so important, because it challenges us to be person-centered, to look at other aspects. Now, one of the things that's often mentioned is holistic care. Excuse me a second. Apologies. Chaplaincy at its best. Someone else has answered it. We talk about holistic care, and the general acceptance of this is that we're all body, mind, and soul. Body is obvious. We are a physical presence, and certainly within the health service as a whole, the body is treated very, very well. Most people come in with an issue, and it's dealt with. I mean, that's primarily what the health service was set up to do. The mind, well, again, we have a lot of services to work with health issues of the mind. But then we come to this wonderful idea of the soul, the inner nature of a person. And it's very interesting that on a lot of forms that we encounter, and certainly quite a few of our referrals that we encounter, when we look at their records when it comes to religion will say non-religious, or even be blank. Because what we've found is that this is a question that a lot of people get quite shy about. Somehow it seems a very personal question. It's really interesting. You'll ask a person a lot about the body or the mind, which again are personal aspects, quite happily. But then all of a sudden let's talk about beliefs, and somehow we don't really want to touch that in the same way. But what we're committed to in holistic care, first of all, is this idea of pastoral care. And certainly in chaplaincy, our idea is to be multi-faith, inclusive of the non-religious, the humanist approaches, providing support and comfort. Pastoral care is relating gently and skillfully with the inner world from all walks of life. It's the elements that go up to make your person's sense of self, your inner resources, your resilience, your capacity to cope. We all need pastoral care. Then, you see, we've got two other types: spiritual care and religious care. So religious care is that which relates to a particular faith tradition, often includes the practices or beliefs of that faith system, prayers, holy writings, food laws, gender, dignity. Spiritual care is addressing these spiritual pastoral needs, then patients, staff and service users, which things like ways to support recovery, issues of mortality, religious convictions, non-religious convictions, relationships, a sense of the sacred, an exploration of beliefs. I think it's really important. I suddenly realised the slides got mixed up. I'm going to jump to this one first of all. Let me explain to you why I consider religion and spirituality different. You've already heard that religion is often structured, has religious writings, is related to a particular faith system. Spirituality, on the other hand, is about what makes you you. And the analogy I was once given is the football. If you imagine that the patches on a football are all the different aspects of your life that matter to you: family, friends, job, recreation, pets, home, finance, and so on. then the essence of you is the air inside, the spiritual that holds it up. For me, spirituality is a question of not what's the matter, but what matters. If you were to ask, the real question that we should ask when we're looking at spirituality is not what's the matter with you, but what matters to you. Because what matters to you is what gives your life meaning. So if it's your family, if it's your friends, if it's your pets or anything like that, it matters. And if it matters to you, it matters to us in chaplaincy, it matters to holistic care. And life has a way of denting the football. We get bashed about, and that's where our spirituality then comes into its own, because spirituality is about reinflating the bashed football, in effect. If we do it correctly, we reinflate. I would always say to people, I believe that everyone has beliefs and values that give meaning to their life. Not everybody has a religion, and I hope you can see the difference that I see between spirituality and religion. So moving back to this one, spiritual distress. When that ball gets bounced about and dented, you get expressions of discomfort and suffering. Sometimes they relate to your relationship that you might have with what you consider to be God or a higher power. Sometimes there's verbalization. People will tell you they feel lost, or they feel empty, lack of fulfillment, or they feel a lack of peace in terms of the relationships. On the whole, it's been the studies tend to suggest we have 6 types of spiritual distress. The first is alienation, that we can be lonely. And as I've said, for many people, this is a major one in hospitals and healthcare, because their world shrinks. If we don't see them as a person, if they're just a case, the person with diabetes or the person in that bed, their world shrinks and support seems very far away. Anxiety, a lot of patients, a lot of people live their life with a sense of judgment and punishment, particularly if they're not feeling so well. Why is this happening to me? Guilt. Now, this is an interesting one because, again, people often talk about, this is happening to me because of what I've done. And they can feel incredibly guilty. Anger. Again, that's one that's encountered often. The unfairness of an illness, of the life, of the situation. Sense of loss. Slightly different to alienation, this one. But this is like they've almost lost their relationship with whatever gives them meaning, with the support, and that feeling of emptiness that carries on. Despair, where they feel hopeless, that somehow they're never going to get anything back, feeling uncared for. And it's been suggested that most patients will experience this at some point. Most of us will experience some of this at some point. I'm not saying by any means suggesting this is linear or this is the totality of it. However, these are sort of like major areas that we need to consider when we're looking at people. Mentioned the football. So one of the things that we do in chaplaincy is we use this tool, and it's called HOPE. We like acronyms, don't we? Is acronyms were acrostics, where each letter represents a different thing. And it's sometimes said that if you want to make a diagnosis with a person, you can ask 4 questions. The first one, what gives you hope? And basically you can then unpick this one, because we're looking for comfort, strength, peace, love, connection. We're all looking for that. What in your life gives you that internal support? And as I say, don't be surprised if somebody mentions their dogs or their pets, because actually they're really important. And I sometimes wonder in hospital, we have visiting times for patients, for relatives and friends. I just wonder sometimes if we should have visiting time for pets and maybe create a special area where people can actually encounter their animals again. When I worked at a hospice over in Rochdale, we were dealing with a patient who had horses, and we were able to get 2 of the horses to the field out back of the hospital and actually take the patient to the fence. So she was able to say goodbye and stroke her horses, and it meant such a difference to her. But I just wonder sometimes, do we put barriers in people's ways? Anyway, some people find comfort and strength in dealing in religious or spiritual beliefs. Is that true for you? And if it's yes, then you can go on to the O and the P. If it's no, one of the questions you could ask is, was it ever? Because we don't know. I mean, one of the joys of the job is to being able to ask questions. We get scared of asking each other questions, and yet, if we're honest, we do like to talk about ourselves if we're asked by someone who genuinely cares, if there's a genuine reason. And sometimes it's about actually stopping and having that excuse me, connection and that contact. Then if you can follow that with, if a person does follow a tradition, do you consider yourself part of an organized tradition, or is it important? What's important? What would be helpful to you? And is it helping you now? Because that's the other thing as well. Just because someone tells us they have a belief system doesn't mean at that point they necessarily want to express it. So, for example, in the Hindu tradition, one of the things that we are often told is that when a person is very, very ill and considers that it might go one way or the other, they like to lie on Mother Earth. However, I've not yet met a Hindu patient in any hospital that would thank you for yanking them out of bed and putting them on the floor because you think that's where they should be. I have met patients who thank you when you actually ask them what would support you at this point. Equally, I once was called by a nurse who was very concerned. She was looking after a Jewish woman and her son was visiting, and the son was having a sandwich. It was a bacon sandwich. And she was quite concerned about this because she thought he must be severely distressed because this is not, this is not part of the faith. She understood that, there were dietary laws. And I came and had a chat with him and just mentioned in passing that he looked like he had a very nice sandwich. And he said, oh, yes. He said, it's a bacon sandwich. I said, oh. He said, oh, I'm kosher on the Sabbath. So he'd interpreted his tradition in a way that meant something to him. It might not necessarily be what the great writings say about his tradition, but that was his interpretation. And if you're dealing with a person, you're dealing with them as they are and where they're at. So if we've got that, then this is back to what their personal practices, where are they coming from? What aspects would matter to you? Because again, for some people, their practices will matter immensely. For some people, their practices will be, sort of in abeyance. So, for example, we one of the things that we are able to offer people is Holy Communion. However, some people who come from traditions where they don't wish to receive communion from a woman, and we'll respect that as far as we can. But obviously, if Sonia or Joe are on call on a weekend, they're the ones who are bringing communion round. That person may then have to wait till during the week. But personal practices are really important, and we only learn about them, what matters to you, by actually asking that question, what matters to you? And then the final bit is the really important bit for us. Being ill affects your ability to do things that usually help you. So what's going on for you? And how does your belief system affect medical care? Because this is one where usually, again, the barriers go up and we try to fit them into the medical model, which sees them as a person to be, a body to be treated. And I think if we step back sometimes, our treatment processes, like for example with the dietary restrictions or the use of blood products, can be so better improved just by asking a few more questions, because our beliefs affect how we feel, how our bodies react. I mean, probably I can remember as a child sort of thinking, if you didn't want to do something, you could think yourself into having a headache. Well, if you can do that, you can think yourself at times into feeling brighter. not necessarily medically, but emotionally brighter. And that can have a big impact on the way your treatment develops. I just float that idea. So if we're making that holistic care, this is one of the big things. Your body, mind and spirit. You're in a strange environment. It's gonna dent you. It's gonna dent your football a bit. But if we talk about being truly person-centered, then we've got to respect the patient's role. If we're placing them at the center, then we really have to respect them and having them take part in the process, because their self-care is important. It's not just us caring for them, it's also helping them to care for themselves. And hopefully we're looking at hope, dignity, self-discipline. So for example, I think one of the great pastoral care in the hospital is the pajama paralysis. I think it's fantastic. I think saying to people, there's no reason for you not to get up, get washed, get dressed, is fantastic. That is, holistic care in action. I think it's fantastic. But holistic care should lead, and the studies tend, more effective and efficient care, because when the patient's fully involved, the patient fully participates as active rather than submissive. Higher job satisfaction for us, because I believe passionately that all staff want to do a good job. And sometimes it's about seeing the benefit you bring to patients that gives us that satisfaction. And I also like the fact that if we get holistic care correct, get it right, the number of complaints drop, because when we feel that we're being cared for in body, mind and spirit, we feel whole. And when we start to feel whole, we feel better, even if physically, there are still issues. So it's provided by all who work in health and social care, patients, friends and carers. Your chaplains are your specialist care providers, obviously, because if you're having difficulties, we're here for you. As I say, so we're a resource with specialist knowledge and skills. We're here to enable. We're here to affirm you, because I do believe that in the different disciplines, the spiritual care is being given, but sometimes we need to re-emphasize it and look at how it's being done. But also, turning it back to to yourselves, it involves supporting staff to reflect on their own spirituality, as well as that of the patients and carers. What matters to you matters to me, but also how are you doing? I think it's so important. So if you want to contact us, we do have a chaplaincy email. We have the main office number. Urgent calls can be done. We are available 24/7. If it's an urgent call, we will respond within an hour to site. All you have to do is ring the switchboard, state the type of support required, because obviously if you want a Roman Catholic priest, it's no good just asking for a chaplain. If you tell them what you want, they will help contact the appropriate on-call chaplain or the non-religious pastoral carer for you. If it's not urgent, well, you can leave us a message on voicemail or email us, and that's our 65935. That's our main office number. We usually have a team member in the trust between 9 o'clock and 4:30 every day, and the voicemail's checked 3 times a day. So I hope I've given you a sort of a broad view of chaplaincy and what our sort of belief system, our main aim is. Any questions?